Support for the Health Channel podcast comes from Florida Cancer Specialists. Florida Cancer Specialists urges everyone not to postpone recommended screenings such as mammograms, colonoscopies, or biopsies. Regular screenings save lives. More at flcancer.com/getscreened.
Welcome to the Health Channel, All Health All the Time. I'm Olga Villaverde, coming to you from the Baptist Health South Florida studios. According to the American Cancer Society, pancreatic cancer accounts for only 3% of cancers in the U.S. What's important to point out, though, is how low the survival rate is for this disease. The overall 5-year survival rate is about 8%, depending on the type and stage of the cancer. But there are different treatments available today, as well as clinical trials that have promising results for the future of pancreatic cancer. Joining us today to discuss the treatment of pancreatic cancer, we have 3 fantastic doctors joining us. Let's start with Dr. Horacio Asbun. He's the Chief of Hepatobiliary and Pancreatic Surgery at Miami Cancer Institute. Also joining us, Dr. Raj Narayanan, Chief of Interventional Oncology at Miami Cancer Institute. And finally, Dr. Ripal Gandhi, interventional radiologist and interventional oncologist, also with Miami Cancer Institute and Miami Cardiac and Vascular Institute. Welcome, doctors.
Morning.
Morning. Thank you.
Thank you so much for being here. First, I want to start with just educating the public on, your roles at Miami Cancer Institute and what you do when it comes to pancreatic cancer and pancreatic surgery. So, Dr. Asbun, let's start with you.
Thank you, Olga. Good morning.
Good morning.
Thank you for having us here.
No, thank you for being here. It's a pleasure.
I'm the Chief of Hepatobiliary and Pancreas Surgery at Miami Cancer Institute and Baptist Health South.
All right, and Dr.
My name is Raj Narayanan. I'm the Chief of Interventional Oncology at Miami Cancer Institute and an interventional radiologist at the Miami Cardiac and Vascular Institute.
And Dr. Gandhi, your role as well?
Yeah, I'm an interventional radiologist and an interventional oncologist at both the Miami Cancer Institute as well as Miami Cardiac and Vascular Institute.
All right, and as I mentioned earlier, doctors, pancreatic cancer, it accounts for only 3% of all cancers. The number is very small, so it isn't very common, is it, Dr. Asbun?
No, it's not that common, but the importance comes because it's one of the most malignant cancers, as you have said.
Exactly.
And traditionally, we have not had enough funds to do research just because it's not as common as other type of cancers. Now we're starting to have a significant awareness of the disease, and that has helped us to make a lot of progress.
And we've had significant awareness because of certain celebrities in the news. Just recently, Aretha Franklin, the soul singer, fantastic, may she rest in peace. She passed away from pancreatic cancer, and back in 2011, of course, we can't forget, CEO and co-founder of Apple, Steve Jobs, also passed away from this terrible disease. So when something so unfortunate happens to, big names like these, the awareness does grow. Is that correct, Dr. Gandhi?
Absolutely. I think having celebrities diagnosed with this cancer definitely raises the awareness of the disease. And as Dr. Asbun stated, despite, some of the advances in the disease over, the last, many years, there really hasn't been a significant improvement in survival until more recently, with improvements in surgery and some of the therapies we're going to be talking about today.
It's Dr. Asbun. I wanted to go through risk factors to start off the conversation on this. Family history seems to be number one.
Yeah, yes and no.
Okay.
I mean, if you have several members of your family, especially first relatives, yes, it is important. However, if you have had a single relative or you have a couple of relatives that are far away from you, then it is not that important as so.
So it's more proximity, like a mom or dad?
That is correct.
Or a grandparent?
And the number of family members that they have had it.
How about diet? How does that play into this and obesity?
Diet plays a significant role as in any other cancer in terms of obesity. Alcohol is important because there's a clear association between alcoholic pancreatitis and chronic pancreatitis and pancreatic cancer.
All right.
What is important too is smoking.
Yes, smoking seems to always be on these lists of risk factors.
Unfortunately, yes.
Yes, and
or fortunately, because it's something that theoretically we can act upon.
Absolutely, it's something that we can do, and we should never start. Let's just put it that way, right?
There's correct, yes.
Race and gender, Dr. Asbun?
There are some studies, but would be difficult for me to make a clear statement about it.
Okay.
It can affect at different ages. There is certain decades of life that is more common, but more and more we're seeing pancreatic cancer cancer at both extremes, younger as well as older.
All right, and then the last one, pancreatitis, what is that?
Pancreatitis is inflammation of the pancreas, and as I had mentioned, one of the types of inflammation of the pancreas is caused by chronic alcohol use and or abrupt excessive alcohol. And when that happens in repeated manner, the pancreas gets inflamed and gets scarred. The scarring produces fibrosis, and in the long term, that can lead to cancer.
Dr. Narayanan, let me bring you to the conversation. I've noticed that pancreatic cancer is not often detected at early stages. Why is that? It seems like once you get the diagnosis, we're already talking stage 4.
Yeah, that is one of the downsides of pancreatic cancer, one of the main ones, because most of the patients have vague symptoms and typically don't seek medical help for that, and you put it away, and many of them are actually diagnosed when they go to the emergency room or to their physician for another problem, and they get scanned for that. So that's when usually they see that there's a problem with the pancreas, or they wait for some time and then they start seeing that they're jaundiced, and there is go to the physician for that, and that's when the investigations have started. So typically it's diagnosed late. Usually by the time they're diagnosed, nearly 50% of these patients would have the disease outside the pancreas.
Exactly.
And it has metastasized.
It has metastasized with it. We want to also now educate our viewers on the symptoms you may have. Dr. Narayanan mentioned some of those, but Dr. Gandhi, let's talk about these. And yellowing of eyes or skin, why does that occur?
Yeah, that's what we call jaundice, and that's really due to obstruction of the bile ducts by pancreatic cancer, typically for pancreatic cancers that are located in the head of the pancreas, as Dr. Asbun described. Other common symptoms include weight loss, abdominal pain. You could have itchy skin, what the medical term is pruritus, dark urine, or pale or greasy smell-filling stools are common as well. And patients commonly might experience some nonspecific symptoms as well, some fatigue, tiredness, and sometimes a lot of these specifics are nonspecific, and for these reasons, unfortunately, a lot of these patients are diagnosed late in their stage.
All right, and speaking of stages, Dr. Gandhi, we talk a lot about stages in terms of cancer, stage 1, 2, 3, and 4 obviously being the worst. This is used for pancreatic cancer too, but you also categorize, when it comes to pancreatic cancer, on how it's advanced. So Dr. Asbun, can you touch upon that a moment of what that means, how much it's advanced? I believe it's called resectable borderline.
That's correct. The term resectable means that you can actually do surgery and take it out.
Okay.
Because today we have multiple different modalities that we'll be talking about, but there's no doubt that the only chance for cure is when you can actually take the tumor out with surgery. Then resectable means so you can take the tumor out. Now we have different stages, because you can have a small early cancer that you take the patient directly to the operating room and it becomes resectable, or you can find a patient with what's called borderline resectable. Borderline means that it's locally partially advanced, not like we showed before with metastasis branches far away, but it's locally advanced. What happens is the pancreas is in the back of the abdomen and it wraps around some very important vessels. Then borderline resectable, the term was developed stating that it has a relationship with those vessels, either wrapping it around completely or not, and I'm not going to bore you with the details of the definition. But once it's borderline resectable, then it is a ring bell for us to say, okay, now this patient probably should go first to other therapies like neoadjuvant therapy. And then it goes first to the oncologist. We're very fortunate at our institution at MCI to have a great group of oncologists that allow us to treat this disease and make it from borderline resectable to resectable.
All right, and I also understand that there's always what you all call a multidisciplinary care at Miami Cancer Institute. Dr. Narayanan, can you explain what that is, please?
I think a well-formed multidisciplinary group is crucial for any cancer institute, and also for delivering bring high-quality care to cancer patients. And we're fortunate at the Miami Cancer Institute to just have the same. We have world-class physicians from multiple specialties, from hepatobiliary surgery, medical oncology, radiation, and interventional oncology, which is our service, all working together. We meet every week regularly where complex cases are brought to the tumor board and discussed. It allows us, for each one of us, to give in, to share our opinions about what we could bring to the table, and thereby delivering the best possible treatment for this particular patient. So,
and I really appreciate that, because it's an individual approach. You examine each patient on an individual basis, correct, Dr. Gandhi?
Yeah, I think that's really the key. We personalize care.
Right.
So you have all the specialists. We all meet together to discuss each individual patient. We review their imaging, their pathology, any treatment options that the patient had before, and really determine what is the best option for this individual patient. And one of the other things I want to add is that Miami Cancer Institute is part of the Memorial Sloan Kettering Alliance. And what that means is there are 3 hospitals in the United States which are part of this MSK Alliance. And this allows us access to broadened clinical trials and advanced studies, which is really key when we want to advance the treatment of cancer.
Dr. Asbun, I'm going to take a quick break, but would you like to add something real quick?
Yeah, I mean, I just want to tell you, Olga, this looks like advertising. We're advertising, but it is not.
No, I actually think it's fantastic.
Right, in fact, several of us have come to this institution recently from very good, well-named institutions because we like the vision, and we like the fact that we all work under the same roof, and we can even see patients together. Then the patient has the opportunity to have multiple opinions. It's like, one of the things that are important is to see a second opinion every time. In this case, you have a second, third, fourth, or even a 20th opinion, because on our disease boards we have multiple physicians that are top leaders in their field and can give the patient a second, third, and 10th opinion.
You called it advertising. I called it empathy. I, at that moment, was thinking of, if I had a family member who was diagnosed, I would want to be in your hands, because it really seems like you take that personal approach. And at that moment, when you get the diagnosis, this is what you want.
That's correct.
Absolutely.
So empathy, I think, is the best word to say for all 3 of you. Thank you, Dr. Asbun, and all of you. We talked about briefly or I teased, I should say, the Whipple procedure. I've heard about it. First of all, what is it, and has it been around for a while?
When you have pancreatic cancer, depending the location of the tumor, you're going to do different procedures. The most common location, or at least the better known location, is the head of the pancreas, and when the tumor is in the head of the pancreas, you need to do what's called the Whipple procedure. Now, the Whipple procedure has a really bad reputation because years past, the majority of the patients had a lot of complications, and the mortality was quite high. And on that, we did have a significant improvement over the last decades. We do now the procedure very safely. The mortality has dropped to less than 4%, and that's for all comers. And the patients go home now, if you do the new techniques, in an average of 5 to 7 days. The complications rate are still significant. However, it is a group of complications that are much milder than what they were in the past, and the majority of the patients go back to a normal quality of life.
Major procedure, no doubt about it.
There's no question. It's
okay.
a major procedure.
Major procedure. How long does it take? What's the recovery like for the patient, doctor?
All depends how complex the procedure is for that patient. It can take anywhere between 3 and 7 hours. Sometimes we need to take portions of the vessels that are neighboring, and that makes it even longer.
Okay, how long does the patient stay in the hospital? A few days?
Yeah, today we have enhanced recovery, meaning a process through which the patients have a better experience during the recovery, and they stay in the hospital between 5 and 7 days.
Can this affect how you eat and drink in the future, doctor?
It does, particularly initially, but as the drawing depicted, if you are able to preserve the stomach, the majority of the patients go back to normal eating after a couple of months.
All right, now just like with any surgery, even though this is a major surgery, there are risk factors. We want to show you some of those. And Dr. Asbun, let's walk through these quickly if we may. Bleeding, infection.
Yeah, delayed emptying of the stomach, that's because of the stomach is divided, and you can have leakage from pancreas or bile duct connections, and that's the one that's most feared, and that's the one that over the last several decades we have done major strides because working with our interventional radiologist and what we call a rescue team. Here we circle back to the multi-specialty team and approach. The surgeon is no longer the only one that treats these patients, and if I have a very good rescue team, the patients do much better.
All right, and I understand that this procedure can be done laparoscopically. Is that correct?
That is correct. Laparoscopically means that we do the surgery through small incisions. In these small incisions, we put a cannula. We insufflate the abdomen to create space.
Right.
And the telescope that's connected to a camera reflects the inside image into the screen, and then we do operation watching the screen. It's basically playing fancy Nintendo and having fun on it.
Nice humor right there. Is everybody a candidate for something like that, or?
No, I think that it's very dependent on the experience of the surgeon. These are not techniques that are yet practiced all over the world, but they're very selected centers with experienced surgeons, and the selection of the patient depends on where the location of the tumor is, and more than anything, it's a balance between what the patient has and the experience of the surgeon.
Before we take a break, I was going to ask you, what do you hope people take away from seeing this procedure and what this does for them?
I think it's important to know that the procedure is safe. Even among the medical community, many people, when they hear the word Whipple, they tell the patient, no, that's, you're going to do very bad. Today is a very safe procedure. Still very complex, but it is a very safe procedure and gives the patient that chance for cure that is so needed.
Thank you, Doctor, very much. All right, Dr. Narayanan, we were talking, of course, about the Whipple procedure. Yeah. Now, there is a newer treatment, and it's called, and if I say it incorrectly, please correct me, but sure. Irreversible electroporation.
Perfect.
Fantastic. IRE for short. So let's talk a little bit about this treatment and how does it differ from the Whipple procedure?
Sure. So the Whipple procedure is a surgical procedure. Irreversible electroporation is a procedure that is considered an ablative modality. This technology was introduced back in 2009.
Oh, so it's relatively new.
It's relatively new, and it is FDA approved for use in surgical ablation of soft tissues. So when we use it in the pancreas, it's considered off-label. Initially, the technology was developed in UC Berkeley. It uses high voltage, low energy DC current, and you place needles to bracket a particular area in the body. Mm-hmm. And once you connect, the needles are in the right place and you connect it to the generator, it delivers up to 3,000 volts of high voltage, low energy DC current. And what that does is it creates multiple pores in the cell membrane. Anything that's in between these needles gets electroporated. In other words, there are multiple holes in the cell membrane, and that leads to disruption of things going in and out of the cell, and that kills all the cell organelles. And that's typically how the technology works and kills the cells.
So I'm going to ask you the same question I asked Dr. Asbun, which was with the Whipple procedure, and he told me it's done when the cancer is localized in the pancreas. Is the same for this one as well?
Yes. The ideal patient for a percutaneous treatment with the nanoknife would be somebody with localized cancer with a disease that's confined only within the pancreas, but also based on our experience, we noted that patients with a tumor size less than 3 centimeters do better than those who are bigger.
And can you explain to me, or to our viewers, I should say, the high voltage electricity, how does that treat the cancer? Does it kill it?
So it is a localized treatment when you're exposing the cells, tumor cells, to such a high voltage of electricity. The way the cell dies is because the energy creates pores or holes in the cell membrane. Okay. So in the tumor cell membrane, mm-hmm. and that disrupts what we call the homeostasis mechanism, which is stuff going in and out of the cell is disrupted, and anything inside the cell dies. And this is how the cell death occurs.
Is this minimally invasive?
It is considered minimally invasive because we're using imaging guidance. The same procedure initially, when they started treating pancreatic cancer with this technology, was done in the open setting, in the operating room. So back in 2010, I started this technique to treat this without surgery by just using imaging guidance. So it is considered minimally invasive.
So there are a lot of benefits as opposed to, let's say, that open surgery.
The key benefit would be that the recovery time is much faster,
exactly.
And the hospital stays is a lot shorter. They typically stay in the hospital for a day or day and a half.
All right. Well, just like any surgery, I always have to say there are potential side effects. So let's take a look at some of these and let's chime in on them. Some pain, doctor?
Yes. Yes.
minimal pain, or
usually pain is a very subjective symptom.
Exactly.
So most of the times the pain is something that can be tolerated by patients on a scale of 0 to 10. We would say about 5. Inflammation is something that is expected. Pancreatitis, around inflammation around the pancreas, is something that we talk to patients about. Problems with eating and drinking, not usually very common. And formation of blood clots anytime somebody is hospitalized or prolonged in the bed rest, that is usually a risk. But with this particular procedure, one of the key things we worry mostly is about the abdominal pain and discomfort.
I wanted to touch upon something that you mentioned a few minutes ago about this procedure being used for pancreatic cancer off-label. Can you explain that for us?
Yes. Many of the technologies that we use is considered off-label. The reason we say it's off-label is that the FDA, US FDA has approved it for given it as general indication called the 510K. In other words, it's approved for surgical ablation in soft tissue. And when you use it in a specific organ, that's considered off-label. But this is something we always discuss with our patients when we see them in consultation. And again, many of these technologies have been around for many years, and there's a lot of data that has been published. And some of them, we are in the process of working towards trying to get a specific indication.
And what is, in your opinion, doctor, the prognosis for patients who undergo this IRE treatment?
So at this point in time, we do not have randomized controlled trials or studies which have been done in a prospective manner. Most of the literature that has been published from the United States on IRE in the pancreas has been retrospective. But what we've shown is that we've been able to provide a survival benefit to these patients of approximately 14 months from the date of the procedure. Clearly, this has to be validated in bigger studies and in trials, but clearly there has been a signal because the numbers seem to be consistent both from the surgical literature and in the percutaneous literature, and also in other centers around the world where this technique has been used and the data has been published. The numbers seem to be encouraging and providing a signal that there is indeed possibly a survival benefit here.
That's fantastic. What do you hope people take away from learning about this treatment, doctor?
The key takeaway message is that today there are other treatment options available. Traditionally, it was either just chemotherapy. If you're a surgical candidate, obviously that would be the best choice, but if not, patients just got chemotherapy or maybe chemotherapy and radiation. And most of the times, interventional radiologists and oncologists were just involved in palliative procedures. But now there is a treatment option that we can also provide where we can help patients. So there is one additional option, which in this particular space is huge.
Great stuff. Thank you, doctor, very much. Thank you for sharing that with us. Why is treatment improvement urgently needed when it comes to pancreatic cancer?
Yeah, I think that's a great question. You know, as you stated earlier, the 5-year overall survival for patients with pancreatic cancer is, unfortunately very poor, less than 10%.
Right.
There's about 55,000 patients who are diagnosed with pancreatic cancer each year. About 45,000 patients die from pancreatic cancer alone in the United States each year. So we really got to do better. And, I think there's a lot of promising technologies that we've discussed today. And there are other clinical trials and newer technologies which are really on the horizon right now.
Now that you mentioned clinical trials, I was reading here, there's one called Tiger Pack. Can someone chime in on what that is and what it's doing?
Yeah, so this is a clinical trial that we are involved in here at the Miami Cancer Institute and at the Miami Cardiac and Vascular Institute. And basically, this is a clinical trial in which we utilize a small catheter, which is actually placed in the arteries, actually feeding the pancreas. And through this catheter, we actually administer chemotherapy directly to the pancreatic tumors. So what we're doing here is a phase 3 clinical trial. And basically what that means is that is really the standard of care when we're looking at cancer clinical trials, where we're comparing the standard of care, which is systemic chemotherapy, to this therapy, which is intra-arterial delivery of this chemotherapy, and patients are randomized either to standard therapy or this arm in multiple centers across the United States. And the overall goal is to see if this improves overall survival.
Wow. How long is this procedure, and are there any side effects to it, doctor?
Sure. The actual procedure takes about 1.5 to 2 hours, I would say. And this is done over a course of 4 months, every 2 weeks. So either patients are given regular chemotherapy or they're given intra-arterial chemotherapy through this balloon catheter. In terms of side effects, you have all this, similar side effects to chemotherapy, although I think these may be minimized given that it's localized directly to pancreatic cancer. And then there are, some risks of just going into the artery, bleeding being the major complication, but that's extremely rare.
God bless you all. Thank you so much, Dr. Asbun, Dr. Narayanan. It's been such an honor having all of you.
Thank you.
Pleasure. Thank you.
Please come back again. And thank you so much for joining us today on the Health Channel. Please be sure to join us next time. Remember, it's All Health all the time on South Florida PBS. Follow us on Facebook and Twitter at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. You can also visit our website all the time. It's allhealthtv.com, 24 hours a day, 365 days a year. It's here for you. You can watch a live stream of the Health Channel. You can watch videos from previous episodes. I'm Olga Villaverde. God bless you all. We'll see you next time.